Today we are going to talk about operative vaginal delivery. Now, operative vaginal delivery is a topic which is becoming rare and rare for the undergraduate level because we don't want you to be performing forceps and vacuum deliveries. But if you are posted to a remote place, or if you don't have anyone else in the labor room, even in a major center, as a doctor, it is your duty to ensure that the mother and the baby are well and baby is delivered in case of emergency. So you need to have some idea how to do it safely and what are the problems and what not to do, especially when thinking about using forceps or vacuum deliveries. So unlike in the past, we don't expect an intern or a normal medical officer to perform these things, but in case of emergency, we expect them to be capable of applying it to save the baby in an emergency. So better to learn it properly. Okay. So now vacuum deliveries and forceps deliveries are the number of deliveries done by these methods are becoming rare and rare in the world. Not only ours, it's even in other countries of the world, it's becoming rare. There are several reasons. One is medical legal. Most of the time, forceps or vacuum deliveries are done in an emergency to deliver the baby or help the mother. And in those situations, invariably there's a complication or something, potential damage to the baby or the mother. And when you apply and deliver, whatever happens, it is attributable to this delivery method. So most of the cerebral palsies are unfortunately attached to forceps deliveries, but it's not the forceps which actually caused the cerebral palsy. It's the condition of the baby hypoxic damage which has occurred earlier while in utero or during the labor before the forceps is applied is the reason for the hypoxic brain damage and neuronal damage. But medico-legally or in the public, those things are not understood. So unfortunately, the operator who did the delivery as well as the method which is chosen is blamed. So it's an unfortunate situation. Because of these medical legal issues, social pressures, delivery rates are going down. But in skilled hand, in properly selected cases, these deliveries will definitely be much more safer than a cesarean delivery done at the last moment with the head in the perineum. So these are essential knowledge and skills a person who is handling a labor or delivery should have. So when should we need to consider operative delivery options? In other words, what are the common indications? The first and foremost, it's to save a baby, presumed or imminent fetal compromise. If that is there, you need to deliver. So common situations are severe variable or type 2 decelerations, even with pushing, if it is not recovering, when the head is at +1, +2 or in the perineum, obviously you need to get the baby out, and these forceps or vacuum are the best to do that rather than arranging a theatre which will take at least 30 minutes to 45 minutes to get the patient to the theatre and do the delivery by a cesarean. So these are life-saving and much more convenient and less traumatizing for the mother and the baby, and less risky as well. Then next indication is maternal indications of a severely compromised mother, either severe cardiac disease or CNS disease with say aneurysm or previous CVA history. Those are the patients who should not really be pushing. Say severe pulmonary hypertension, heart failure due to mitral stenosis. Those cases need help at the time, and forceps or vacuum are the ones actually more towards forceps than vacuum, because even with vacuum you need maternal effort. So forceps needs maternal effort but to much lesser extent compared to a vacuum delivery. So these cases are classically used for forceps deliveries. Then the third one is the commonest indication when the second stage is prolonged. Prolonged means it depends on the whether the mother is a primiparous or multiparous woman. In a nulliparous, if with epidural, if the mother has been pushing for after full dilatation for more than 3 hours, or without epidural for more than 2 hours, or if there's any signs of a maternal exhaustion, you need to think about forceps or vacuum delivery. In certain cases, like in multiparous women, when after 2 hours of pushing with epidural or after 1 hour of pushing without epidural, again you need to consider instrumental delivery. With forceps, that's another indication to support and deliver safely the aftercoming head of a breech delivery. And even in preterm deliveries, sometimes to prevent the preterm head, even with the cephalic presentation, we might apply a prophylactic forceps to support and prevent sudden release of pressure of the preterm baby's head, especially in case of a precipitate labor. If it is diagnosed, we might do that. This slide is one which shows you all the options in a woman. So in first stage or in second stage labor without the head being engaged, head above the ischial spine, after discussing with the mother and the baby, if there's any fetal heart decelerations or whatever problems, usually you take the cesarean section route and we go for delivery following the cesarean guidelines. In the second stage of labor, or when the head is not palpable abdominally and vaginally head is palpable or stationed at below the ischial spine, you think about doing an instrumental delivery. And then you have choice for ventouse delivery or vacuum delivery or forceps delivery. If you are not sure which one to use, then probably you are not the best person to deliver. Call your seniors, SHO, senior registrar or your consultant, and discuss and get them involved. But if you are skilled enough, you should choose either vacuum or forceps. The relative reasons for choosing either of them we will discuss later in a couple of slides later. And once you decide to use one of them, you need to see whether the appropriate criteria are fulfilled. Some of them are here. You need to have good analgesia. Patient should be in the lithotomy position with the buttock lifted up and at the edge of the couch. Cervix has to be checked to be fully dilated. There should not be any ring of the cervix. There should not be any cervical edema. There may be caput of the baby. Molding may be there, but it has to be minimal. And if bladder should be empty. If not, you need to empty the bladder. And if episiotomy is not given after application of vacuum or forceps, you may have to consider once the head is distending the perineum, you need to give episiotomy and give a local anesthesia. And those days we used to give pudendal block for forceps or vacuum. And now the practice is going down. With the epidural, it is not really necessary. Even without epidural, good local infiltration is mostly adequate. And general rule is even whatever method you use, forceps or vacuum, you try only for about 3 pulls. After that, the risk to the baby and to the mother is higher. You need to think about abandoning the procedure and going for a cesarean delivery. And then after the delivery, at the anterior shoulder, you need to give syntocinon or synthometrine or gametrine, double clamp, then check the baby's airway, clean the face, deliver the baby. If there's a fetal distress involved, do a double clamping of the cord and check the cord blood for lactate as well as pH and oxygen saturation. And then check the vagina and the cervix. Especially, you need to check the 4 disease especially if you have applied forceps. Check the vagina completely. It is very easy for us to miss bleeding. Initially there will not be bleeding. After a couple of minutes after you move out of the labor room, you will be called again if you miss them. So always check. And then repair the episiotomy, repair the tears if necessary. Especially after instrumental delivery, we recommend putting a catheter. And then check the swab count, needle count, and then document in details. We will discuss them in the following slides towards the end of this presentation. So these are the conditions whether you are using a vacuum or forceps. These are the list of conditions you need to fulfill. First is the fetal head has to be engaged. Sometimes you might do a forceps even if you palpate 1/5 of the head abdominally, but that is an expert's decision. Your consultant might do it, but generally we advise the head has to be completely engaged without any part palpable abdominally. Membranes has to be obviously ruptured. You need to assess the Lyco volume as a quantity as to assess the fetal well-being, as well as to assess the position of the baby's head. Cervix has to be obviously fully dilated, otherwise you will end up with a disaster. Even say there was a teaching that vacuum can be applied even after 8 centimeters, 7 centimeters, but I have seen people, even consultants, falling into trouble after delivering with vacuum after 7 centimeters. We had to struggle to save them, the mothers. You need to know the position very clearly. Vaginal examination will be helpful mostly, but nowadays the recommendation is to use ultrasound scan in the labor room to get the position correctly. So in future, as I mentioned earlier in a few lectures earlier, labor room practices will be supported mainly with ultrasounds. Assess the pelvis, especially if you are doing it for delayed second stage case. Assess the maternal pelvis. See the type of pelvis. Is it a gynecoid pelvis or android pelvis? Is it narrow, lower down? If it's an android pelvis or platypelloid pelvis, then probably you may have to consider your options and think really hard about cesarean delivery, because even if the pelvis is adequate above, upwards, close towards the outlet, if it is narrowing, so you need to check the subpubic angle, interischial tuberosity diameter, as well as the lateral pelvic wall inside and the prominence of ischial spine. So nowadays these instrumental deliveries, either forceps or vacuum, are not advocated in fetal head station above spine. So those days it used to be the case when cesarean was not possible, but now cesarean is indicated in most of the cases when the head is above the spine. So in the modern practice, forceps or vacuum are for people who have passed the widest diameter of the pelvis, which is the spine, ischial spine level. And you need to ensure analgesia, as I mentioned earlier, and bladder has to be in. And operator should be knowledgeable and confident and trained enough to do it. If not, you need to do it with the help of a supervisor, a trained person, and with their guidance. And you should not be very dogmatic about your choice. Komari deliver karana. That is not the attitude you should have. You should always accept your failure, take corrective action. Your attitude should be to save the mother and the baby in the least harmful way, not to boost your ego. You have succeeded in delivering vaginally. No, that is a wrong attitude. So always keep that humble attitude. You might fail. There's nothing to worry, nothing to be ashamed of. Take the patient to the theatre and deliver. Your aim is to save the mother and the baby and see a smiling mother and the father and the baby going home, not to end up with a maternal death or fetal death. Informed consent has to be obtained. Obviously, there's no time to sign forms or do a proper detailed discussion. But all patients who are coming for vaginal deliveries, at the time of admission, you need to advise the mother and the mother and the husband that there is a possibility of them requiring a forceps delivery. That has to be cleared early and documented. At the time of delivery, you might have to tell, it looks like that we are going to go ahead for forceps delivery. Doing a cesarean at this late stage is difficult, and you need to line out the reasons why you are choosing this instrument and prepare. And most of the mothers are more than happy to help and go with you. And you need to have adequate support and people. Say you need to have a pediatric house officer or pediatrician on your neonatal team there to resuscitate the baby, especially in case of a fetal distress. Adequate analgesics, anesthetics registrar should be there. If somebody who has given an epidural is there to give a top up, that will be very useful. And equipment of resuscitation and resuscitation of the mother should be there. If you have Enteronox, should be running, and there should be people to help with them. There are certain, so those are the conditions, prerequisite for any kind of operative delivery. There are certain things which you should not be doing, or contraindications. In those cases, you should think about cesarean. One is a fetus who is having a problem with their bone. If you go and apply a forceps delivery on a baby with osteogenesis imperfecta, those skull bones are going to fracture, and you will end up with a jelly of a brain in the baby's head, and you will be accused. So if you have any idea about the diagnosis, avoid forceps or vacuum. If the baby is having a severe bleeding disorder, or even immediately after applying a scalp electrode, or after doing scalp blood sampling, we don't do them now, but if those things have been done, then you should avoid. Babies with von Willebrand's hemophilia history, suggestive of a hemophilia history, should not be taken for forceps, so vacuum deliveries mostly. If the head is not engaged, obviously you are not considering any vaginal delivery. If the head position is also not clearly known, you don't have access to ultrasound, and it is loosely applied when you put your finger, the head moves up, not a good idea to try for instrumental delivery. And there are certain specific contraindications for vacuum deliveries, like the baby being less than 34 weeks, or there is a risk of because of intraventricular hemorrhage in the fetuses. And in face presentations, you can't. In brow presentation, as we discussed last time, obviously no way in delivering with any instruments. What should we use, whether vacuum or forceps? Actually depends mostly on those contraindications for vacuum as well as the experience of the operator. So if you are more familiar and you feel more confident with vacuum, always go with that. If not, if you feel forceps, go with that. These are the relative merits or reasons for and against both of them. Vacuum with modern Kiwi vacuum devices compared to old electric pump vacuums, it is much easier. Actually, it is much quicker than even a forceps delivery. Delivery is but slower, not quick. So if you want to do a very quick delivery, probably not a good idea to go for vacuum. Scalp trauma, especially if you apply it into a very dematous caput, you will have scalp trauma. Increased risk of intracranial hemorrhage is there. High rate of failures. So if you really want to deliver the baby, probably forceps is better if you are trained. And obviously under 34 weeks. These are in the things against and for vacuum. Forceps, of course, difficult to apply, especially mid-cavity. Wrigley's, of course, is not a big issue. They don't do much damage because they don't go high up. But Neville Barnes or Simpson's forceps, which are strong, bulky, long forceps, and even with Kiellands, which are long forceps, you need to really know what you are doing. Otherwise, you will end up damaging the mother's vagina and tearing it and stop. There will be a massive hemorrhage without, we will not be able to save the mother. You need to, you can get a very fast, quick delivery. Obviously, increased risk of maternal trauma compared to the fetal trauma. So the forceps are harmful for the mother, mostly safer for the baby. And baby is more prone to potential injury. It requires better analgesia. May be used as at any gestational age as well. So forceps are generally, if the operator is familiar and if the delivery is needed early and preterm baby, this is the method to use. So before taking up forceps in little detail, we'll look at the anatomy of a forceps. These are normal traction forceps. There's a classification which we will come in a minute. All forceps have a handle, they have a lock, and they have a shank, and they have a blade. The blade is special because there's a hole or fenestration in the middle to reduce the bulk. Initial forceps were made out of wood and then replaced with metal, and all of them were bulky. To reduce the mass and to be very light, they took off all this middle part because it's not doing any purpose. There are still some forceps used in other countries which has a complete metal blade, but they are a bit bulky. It has two curves. One is the pelvic curve. If you can remember in our first discussion of labor mechanisms, I told you that the pelvic birth canal is a J-shaped one. So to accommodate that, there is a pelvic curve. There are forceps without pelvic curve like Kielland's forceps, which is used for rotation, and it has to be applied in a special way because if it is applied in the normal forceps way, it will tear the maternal vagina. So this pelvic curve will prevent that damage happening in the mother. Then to accommodate and fit the baby's head, it has both blades when assembled will have a cephalic valve. So forceps come in two blades and they have to be articulated or they have to be locked in front of the pelvis, and you need to identify left blade and right blade. If you are right-handed, generally we take the left blade first. If you are left-handed, you take the right blade first. And then usually if a right-handed person is operating, you put the left blade first. Left means the left of the mother's abdomen and mother's side. So left side of the mother is the left blade. Blade which goes onto the right side of the mother or the right leg of the mother is the right blade. So you need to identify that. And before all forceps, always assemble the instrument in front of the mother. And it is not surprising for you to see that sometimes these blades are not locking properly. So this is the classification. The common classical forceps are called traction forceps. They are used for mainly applying traction. And it has cephalic and pelvic curves. Wrigley's traction forceps, which is used for outlet, very low cavity deliveries. Simpson's and Neville Barnes are for mid cavity, and it can be even applied above in a very accommodating pelvis, and very powerful instruments. You can deliver almost anything, but can damage more. They are all traction forceps. Unfortunately, because of this way of teaching, I can't show you, but definitely if you watch the videos I will be uploading to the Moodle, you can have a good idea, and when it is possible to meet you in physical form, I will show you the forceps. And then you have rotational forceps, which are Kielland forceps. It can be used for applying traction, but its main use is for rotating the fetal head in the cavity. And then this shows them in detail. They are not in proportion. Wrigley's is not that long, it's a small one. Simpson's and Kiellands and Neville Barnes are long forceps. And please check them at the labor room. If you speak to the sister, she will show you. You need to identify. And the locks in these things are different. Now Kielland has a sliding lock, whereas Wrigley, Simpson's and Neville Barnes, they have a English lock. Sliding lock allows you to correct the asynclitisms or the prominence of one parietal bone over the other when the head is not rotated properly in a transverse rest situation where it is used. So in modern practice, these three are the ones which are used. Kiellands are rarely used now because most of the time they either go for cesarean delivery or rotation can be accompanied with the vacuum, especially with the Kiwi vacuum. It can be as easily done much more safely than with this instrument, because in untrained hand these can be dangerous. And then these blades are applied, and this is a Burns attachment. It is called separate attachment. It is axis traction handle. In Neville Barnes forceps it is applied. In our labor room there is a axis traction handle. You can see that, and it is used to pull the baby. When you want to apply the traction, it helps you to do it along the pelvic curve. We will talk about it a little later. So this is the sliding lock, or the German lock. It's called a German lock because this is devised by a Danish person, but the lock is called German lock. These forceps are not seen. It's called Piper forceps. Ideally, it is used for cesarean deliveries as well as outlet deliveries, as well as supporting the head of the aftercoming head of a breech delivery. In our country, we use either Kiellands or Simpson's forceps to do that, but these are ideal. We don't have them. This is what the use of the Kielland forceps in rotation. We are not going to talk too much about these devices today. So these are the criteria for type of forceps. Outlet is the commonest thing. When you see the head below the +2 mark of the spine, just at the perineum 1 to 2 centimeters away, perineum is there. Even without separation you can see, but mother is exhausted. Use a Wrigley forceps and you can. The fetal skull is at this floor, almost at the perineum. Sagittal suture is either anterior or within 45 degrees of the midline, sagittal suture, vertical. In those cases, you can do outlet forceps with the Wrigley. Low forceps or mid-cavity forceps are used with either Neville Barnes or Simpson's, and it has to be at least +2 from the spine. Sometimes it may not be rotated. In those cases, you need to see whether you can rotate it manually by pushing the head, or whether you can if it is completely transverse. In that case, you will either use a vacuum or use Kielland's forceps to rotate. And when the head is above the +2, but still when the head is engaged, or the presenting part is below the spine but not +2, +1 also, these are called mid-cavity forceps. Again, you can use Neville Barnes or Simpson's forceps, not Wrigley. And we need to know the steps of applying a forceps. First is to tell the woman, counsel, and get the verbal consent. Always, this has to be, as I mentioned earlier, discussed early. Choose the appropriate type. Now you have decided to go for forceps. Obviously, if you are in a hurry, you want to deliver quickly, this is the choice. If it is outlet, use Wrigley. Low cavity or mid cavity, use Simpson's or Neville Barnes. Articulate the blades and match and identify the blades left and right. Because sometimes even after sterilization from CSSD, they not be sent in the properly packed manner. Ideally, you should label with numbers. Say each forceps blade should be having a number etched onto the handle. Then empty the bladder and remove the foreleg. Don't leave it. And if you have been monitoring or applying an electrode to the scalp, remove them, and always monitor the baby with the abdominal CTG transducers. Confirm the fetal position again, and then apply in between the contraction. When the mother is pushing, you are not going to apply. Ask the mother to take deep breaths after contraction, relax her perineum, and then apply the bomb. And you do 3 checks to see the application. We'll talk about that. And then apply traction with the next contraction. And one in between the pushes, always when you apply traction, the mother has to be pushing. If the contractions are not adequate, you might give them a bit of a syntocinon drip. If she is not on syntocinon, put her on a syntocinon. Monitor the heart rate between the pushes. This is how you check the placement. The sagittal suture should be in the midline between the blades and running perpendicular to the plane of the shanks. Now, if the shanks are like this, it has to be on the same plane and it has to be perpendicular, sagittal suture. And you should be able to push your finger between the angle of the fenestration of each blade and the fetal skull. There should be space. If it is closely hugging the head, probably you are too tight or not proper application. And there should be similar amount of, if you have more than one finger breath space, then same way should be on the other side. Otherwise your head is on an angle manner. Then you need to reapply and recorrect it. So all space between the fenestration and the head should be equal on both sides. And posterior fontanelle should be in the midway between the blades, sides of the blade, and the level should be about 1 finger breadth above the plane of the shanks. The shanks are like this, so it should be 1 finger breadth on both sides. And this diagram shows you the application. You palpate the position, hold the blades with index, middle finger and the thumb on one hand, and then guard the perineum with the other hand, and then rotate it and insert it into the vagina. Same here, guard and then insert. You can see that in the video. I will be uploading it to the Moodle. And then after application, check the correctness, and if you need to apply traction, you can use axis traction with the Neville bands, or otherwise there's a maneuver you can apply. And then with the contraction, you apply the traction. Same. Now when you apply the traction, initially it is downward, and then as the head negotiates and passes beneath the symphysis pubis, you can start elevating. So this diagram shows it very nicely. When you apply the traction, we use what is called a Pajot's maneuver. You are doing it along the axis of the pelvic canal. And this in Neville bands, this Bill's handle or axis traction handle is used, but you don't need it really. You can use this maneuver. You pull with your dominant hand, that's this, and then your non-dominant hand should be pushing on the shank. It's called axis traction or the Pajot's maneuver. And what you are doing is actually your resultant force. If you are pulling this way and pushing this way, resultant force will be like this. So the traction will be along this arm. So that will help. So you apply your physics you learned. If you apply 2 forces, then the resultant force will be in the 45-degree angle. So you use that to deliver the babies and guide the head along the pelvic canal. In occipito posterior position, you can apply forceps, but in that case, you should not be really using the Pajot's maneuver. Because if you use that, you should apply traction downwards, but not to the same extent like in occipito anterior. Because if you do that, then the head will extend and then it will damage the perineum more and might get impacted as well. So you apply the traction adequate for it to negotiate the symphysis pubis to the chin to pass the symphysis and then deliver the baby in a face to pubis manner. because it can cause hyperextension and can even damage the or dislocate the atlantoaxial axial junction. The amount of traction should be very minimal. Actually, it should be applied not in pulls, it should be steadily applied continuous. Intensity should be gradually increased depending on your response. You can feel with your hand whether the head is coming down. And only with the contraction and with the mother pushing. And you should be relax the force when the contraction ends. So your 3 pulls has to be very well coordinated and should be very carefully assessed. Some teachers of ours have actually advised us to use a stool. You sit on the stool and apply forceps. That is the proper way to apply a forceps, and that has to be also with the wheels. So if you pull unnecessarily, you will fall. You will be pushed away. So it will ensure that you are applying correct pressure. And you should not be applying forceps standing up and with your one leg foot pushing onto the bar of the bed and pulling. So your weight should not be used. The force you are using is the force of your forearm, not the arm, forearm. Arm should be here and this, not the biceps. It should be forearm muscles. Right. You don't need to apply the episiotomy immediately the moment you decide. No, you can apply the episiotomy and then when the head is distend the perineum. If the distension is not there and the perineum is nicely giving, you don't need a episiotomy. Sometimes in a multiparous women when we are doing forceps, they don't need episiotomies. And then once the head is distending and when it is extending, you need to start supporting. You can't do that. Your assistant should be supporting the perineum. And then when the head is elevated above, handles are elevated above 45 degrees, you can you should remove, because then if not, you will be damaging the vaginal side walls with the groove. And then remove the blade in the reverse direction. So the blade which came last, which is the right blade if you are left-handed, should be removed first, and then left blade should be removed. And then same way which you used to introduce should be followed in your removing. And then after that you can complete the delivery in the normal manner. Give the ergometry or syntocinon at the anterior shoulder, check for tears, check the side walls as I mentioned, and then see whether the anal sphincters are damaged. And then if the head is not descending, then you should recheck whether your position is correct, your station is correct, and you can try for 3 times, and if not, you need to consider whether this is the right method to do. Don't apply too much of pressure, the force. That is the one guiding principle with forceps. And if it is not descending with your arms and the forearm force, there should be some reason, maybe a CPD. After the delivery, these are the things you need to check. You're not taking. Note is the most important thing. If you want more detail, here it is. Gravidity parity of the mother from the fetus, presentation station, and then the delivery process, so the instrument you use with the application of for correctness, the degree of traction, number of pulls, whether there was dislocation of the cup, or disarticulation or reapplication of forceps blades in the case of forceps, delivery of the time of the baby, placental delivery, episiotomy time of performance, any intrapartum other findings like meconium, caput molding, and the third stage management, and the weight of the baby, baby details, evaluation of the baby and the mother's condition, baby's condition, repair of the episiotomy. All that has to be documented, and needle count, sob count, all that has to be there. And then your instructions for follow-up, like watching for bleeding, syntocinon, antibiotics, catheterization and removal, analgesia, as well as maintenance of Meo's chart should be there. That is what we do with most of deliveries and the forceps delivery. So when you are choosing vacuum deliveries, you don't need to do many things differently. Same principles apply, but the type of instruments are a bit different, so we need to know the modifications which we need to do. Obviously, vacuum is used when the operator is more familiar than the forceps, and there are no contraindications like a preterm baby, or no bleeding tendency, no scalp punctures, anything has been done in the labor. If those things are not there, you can apply a vacuum. There are a number of vacuum devices. So even in our labor, you might see we can use the suction machine to apply a vacuum, and there are vacuum devices, tubes, metal cups, chains and other things. Those are hardly used. When we don't have this device, Kiwi device, we use. There were other vacuum cups, silastic cup is there, but they are useful for outlet deliveries, not for any proper traction. Kiwi is a very good device, very useful handheld vacuum device. It has a handheld pump, traction force indicator. The one which we have here does not have that, but advanced model from which I have taken this image actually tells you the amount of traction you are applying, and that will help you from scalp damage. So it's very useful, and it has the pressure gauge, and you should apply the pressure up to the green level, not go to the red level. So it's help with that, and there's a button to release the pressure, and it has other markings on the tube to see the depth of insertion and groove. So this device can be used for occipital anterior as well as posterior device. It's called Omni cup. There's another Kiwi occipital anterior cup as well, and there's another modification for it for the cesarean delivery. So all these things are there. It's very useful. Invented by a person called Vaccum in Australia. He is no more, but very nice man. He came to Sri Lanka to teach us once. This is the original Malmstrom cup, which was the one which we had earlier. Then we had handheld pumps, bicycle pumps, vacuums. So in periphery you might see them. This silastic cup is there, Kobayashi cup or silastic cup. Those are there. They are soft, easy to use, good for outlet deliveries. And you might see some of these similar things in kitchen as well. To clean your kitchen drain, use this. So kitchen plungers, same principle. They are useful but not good. So Kiwi cup is gradually displacing all the other devices. We don't use metal cups anymore. They are traumatic, use bulky, and takes time to assemble. Vacuum is not different for the forceps with regard to complications, and same prerequisites, same indications are applicable, and you need to you generally using vacuum is, as I mentioned earlier, you have better experience with vacuum, and it has the advantage of needing less pain relief. So, and same as forceps, you apply the vacuum device after consenting, emptying the bladder and checking the position, lubricating the cup, you apply it, and each device has a different way of applying. So it is better for you to watch the videos which I will be uploading to the Moodle, so and can have an idea. And after application, you need to make sure that before applying the vacuum force, always check whether the cup is catching any maternal tissue. And you need to center the cup on the flexion point. Flexion point is very important with regard to Kiwi cup as well as all vacuum cups. It is the point which is about 2.5 to 3 centimeters in front of the posterior fontanel. That is the point of the mentovertical diameter which crosses the skull. So that is the point where the maximum diameter of the head is obtained. And that is the point when the head is well flexed, extended. That is the point where you will apply the force which will be directed against along the baby's spine. So baby's axis. So the pull on the flexion point will direct the force along the axis of the baby, along the spine, and that will help us to get the whole baby out with the maximum pressure force without much damage. Minimum damage, maximum force. So that is what helps us. So you need to use axis flexion point in applying the force. You will see on the videos I will be uploading it much more clearly. And the cup should not be put on either anterior or posterior fontanel. So if you are using cups, especially with metal cups, you need to choose the appropriate size of the cup, small cup or medium size cup rather than a large cup, to prevent either encroaching on the fontanels as well as catching the maternal tissue. And you need to apply the force. It has to be below 500 to 600 millimeters mercury or 0.6 to 8 kilograms per centimeter. So with manual or with the electric pumps, these were very critical because the machines were very capable. But with Kiwi, obviously if you are within the green zone, you are safe. Green zone. And then once you have applied the cup, wait for the mother to push with her coordinated pressure. Again, pull towards the floor. With Kiwi, it has to be like that. You need to kneel down and down on touching the knees on the floor and then pull down. And that will direct your force along the pelvic curve. Like applying triaxis traction, this is the way to do it. While doing that, you need to hold the cup with your fingers. 2 fingers on the maternal scalp, 1 finger on the cup, so that you can detect any early separation or dislocation. And don't rock it. You should always pull down, and then once the head is clear coming up, you should elevate it. Between the pushers, there's a debate whether you should release the pressure or not. At the moment, the evidence is saying that there's no real reason for you to release the pressure. You can keep it. But if you keep the total time duration of vacuum more than 5 minutes, the risk of cephal hematoma is there. People who are advocating release of pressure but keeping the cup there were saying that cephal hematoma risk is reduced, but it is not seen in research. After 3 coordinated pulls, or if the cup pulls off more than twice, then probably you need to think about abandoning. Sometimes it happens when you are applying the cup, especially Omni cup or Kiwi cups, metal cups, in occipito-posterior direction. If that happens, you need to probably, if there's no descent, you need to consider cesarean delivery. So this is how the Kiwi cup is applied. This is how you hold the cup in your fingers. Before applying, you can check the application. This is the Kiwi occipito-anterior cup. This is the Omni cup. The traction is applied initially downwards and then gradually you can elevate it like the forceps. Then so I mentioned that if the descent is there, you might go on applying, probably not appropriate. But sometimes after applying and getting the head down to the perineum, the mother's push might be adequate to deliver. In that case, you can allow her to deliver. But otherwise, if there's no descent and you have done 3 pulls, either with the forceps or vacuum, if the head is not coming down, there has to be a reason. Baby may be large. Even if you deliver the head, you might end with shoulder dystocia. So think about it carefully, assess the situation again, speak to the mother, and then with your senior's opinion, take the patient to the theatre for cesarean section. Because if you follow a forceps with the vacuum, sometimes we have the tendency to put a forceps after vacuum. After getting down the head, you put forceps, but not a good idea, because all the major authorities are advocating against it. If you fail and end up with trauma, it will be very difficult to save your skin from the lawyers. So, if you have any doubt about any method, you should really be doing that as a trial of forceps or vacuum in the theatre with everything ready for cesarean. We'll come to that later in a couple of slides. These are the potential complications. Always tell the mother that you are going to try and see whether the head can be delivered with the instrument. If not, have everything ready. Especially if there's a risk of trauma to the baby or the mother, you need to discuss and then decide. So this again, like earlier slide which I showed you earlier, shows you the mortalities and morbidities of either method. So forceps have risk of gait, 3rd degree, 4th degree tear, maternal discomfort postpartum, you need good training, risk of neonatal facial nerve injury. Vacuum, higher failure rate than forceps, increased risk of cephalomatomas and neonatal injuries, subarachnoid hemorrhages, subgaleal hemorrhages, especially with the rapid force if you deliver, and less maternal anesthesia. This lines up it in a more detailed way. Forceps have higher risk of vaginal hematomas, PPH risk, jaundice risk, cephalomatomas. Forceps. With vacuum, maternal vaginal lacerations, cervical lacerations, PPH, scalp lacerations, cephalomatomas, retinal hemorrhages, neonatal jaundice. Those are common with vacuum. So in case of a doubt, use all deliveries, instrumental deliveries are actually a trial. So if it is outlet or low cavity, the chances of your success are higher. Do it in the labor room, it is okay. But if you are having a high head or mid cavity, get the patient to the theatre, do it as a trial. Most of the time when you take the patient to the theatre bed, the head is either in the perineum or already delivered on the way. So you can avoid the instrumental delivery as well as do it as a trial basis. If you fail, there is no evidence to say forceps or vacuum has long-term damage to the baby. You need to tell that to the mother. At the moment, there are big studies of thousands of babies with both methods. They don't have any learning difficulties. If their prior condition of the baby is good, outcome on the long term are good. Speech, neurological development or learning development are not different from normal babies. And when you are using, when you are counseling, you need to tell these things to the mother. That brings us to the end of the lecture. You can learn more with the videos which you can watch on the Moodle. And bear with me, it might take a little longer because it's a little slower to upload to the Moodle. I will, within next few hours, we'll try and finish that. Thank you.